Good afternoon, everyone, and welcome to the final grand rounds of the 2023-24 academic session. Just like to thank everyone who's either here in the virtual room or as on Facebook, not Facebook, YouTube, got Facebook on the brain. Anyone who's watched these things on YouTube, just to thank you for taking part in grand rounds over this last year. This is 10 years I've been chairing and organising this, or maybe 11. And I'm just delighted that people still want to come along on a Thursday whilst they're having their lunch. And we still have people who volunteer to give these talks throughout the whole year. So thank you very much indeed from me. So for our last talk of the academic year, we have Paula Gardiner, who was in touch with me some time ago to ask for a slot, and she is rounding things off with a talk about functional neurological disorders, something about which I know a little bit. And as I said in my email, I think most of us will have come across people who have this label in their notes, or they tell you have this diagnosis, and perhaps we don't know if we fully understand what that means and what the implications of that. And it's important that we understand where those labels have come from and what we should do about we should help our patients. And Paula's going to talk about why I wasn't taught anything about functional neurological disorders in medical school 35 years ago, and talk about how we can make changes to that. I was explaining to my son last night, he was asking me what Grand Rounds is about this week, and he said, well, how do we not know about what causes things? As I was talking about medically unexplainable symptoms, I suggested to him that 200 years ago, most of medicine was medically unexplainable symptoms. And indeed, even 30 years ago, we had a lot of medically unexplainable symptoms. But hopefully, Paul's going to teach me today so I can go back to my son at tea time tonight and educate him too. Paula, thanks very much for your patience with fitting a slot in for you. And thanks for rounding off our grand round session. If you have any questions in the audience, please put them in the chat and we'll get round to them at the end of the session.
Excellent, thank you. Thank you for the introduction. I'll give you just a very brief background because you'll wonder why I'm presenting some things in this talk. And it feels like a lifetime ago that I trained as a neurological physiotherapist initially and specialised in functional neurological conditions. And that seems, well, it was many, many years ago. And it was really through working with psychology and training with psychology that I felt a greater need for my development in my career, and so then did my master's in CBT and some psychology training, etc. And went on to work with, I'll introduce the team in Edinburgh, John Stone and Alan Carson, the sort of world leaders in FND, and so privileged to work with them. And now I work as a tutor on the clinically applied psychology course at Dundee University. And I'm always flying the flag. I still do clinical private work with John Stone, and I'm always flying the flag and feel it's such an important area that we all as clinicians usually face at some point meeting this condition, and feel it's really important to understand it better in order to get better care. So I'll fire on and work through. So functional neurological disorders, have some slides at the kind permission of John Stone as well, so I recognise that. Historically, it's all in your head, and patients have reported that they've been told this and this phrase, and again, not very helpful. And what does that mean to patients, and what does it mean to clinicians working with them as well? How do you deal with that? And is it? So starting the definition, I'll go on to explain about the definition for FND. But there are conditions where patients experience neurological symptoms, but there's no structural damage to the nervous system. And in my sort of 30 years career of working with this condition, I have seen a huge range, and I'm going to introduce you to the sorts of symptoms, and I've got some videos of patients to share with you. And I'm sure a lot of you here today will have come across it. But that can be anything from someone who presents in A&E that looks as if they've had a stroke, and so weakness to the limbs, balance disorder, speech problems. There may be a mixture of symptoms there. But when they go through your normal testing, MRI, etc., these tests are coming back as normal or nothing wrong, or the patients are told there's nothing wrong with you, which again, I'll talk about, is not helpful for the patients. And it's not true. So assessment will often, depending on the type of assessment you do, the assessment will often demonstrate that normal function of the nervous system is possible. And I'm going to talk a bit about assessment because depending how we do that, we want the patients to see that in a hopeful way rather than we're tricking you. You know, look, you can move your arm. There's reinforcing that there's nothing wrong with you, or I don't believe you. And actually part of the diagnosis and assessment can actually, we know through research, can actually be a massive part of treatment, and patients get better just by knowing what they've got. And there's a lot of papers out there. You will historically have heard, and they're still used, other names. Again, as I go, I've got some papers up there for you, and obviously in the time I've got, I don't have time to go through all of them, but I can make access to this presentation. But functional's at the top of the list in my mind, and it's one that's come through as the one that the patients prefer, because functional neurological sense, there's an alteration to function. They can't function in some way. But you'll have heard of psychogenic, non-organic, medically unexplained, and I'll explain why I find that one difficult. But again, everyone may choose their own. And when you're searching to look at literature, a lot of those names may well still be used. Somaticization, conversion disorder, or often just to say that the tests are normal. And again, historically, Paget, quite a very famous medical man for Paget's disease. And I like the way he described it. He or she says, I cannot. It looks like I will not, but it is I cannot will. And as we understand the condition more, we see the more the patients actually try to will the improvement or will the movement, you know, like the movement, if there's a movement disorder, it actually can make the condition worse. So it's making it non-automatic in a sense, and I'm going to talk about that a little bit more. So I like that, the way that's explained there. So this is the group that I'm in the alumni and ongoing collaborators section now, looking a lot younger there, which is a bit depressing. So this is part of the FND research group that's still ongoing in Edinburgh and always looking for collaborators if anybody's interested. And we have a core library for FND, which you can scan and access to. It's a Dropbox where current papers, collaborators, etc., have put into, which is really helpful for people. So about 30 years ago, really, I started working with John Stone and Alan Parson, and primarily as a clinician. So being involved in a couple of major studies with them, and still work clinically with them, do some private patients with them still, and work clinically. Okay. So historically, conversion disorder, whatever name, was profoundly neglected 20 years ago. And the diagnostic criteria, you know, was a contributor to this. The DSM-4 made a trauma history essential, but not all patients had. And it also required the exclusion of neuropathy and feigning, which was not usually possible. The DSM-5 has dropped those requirements and require a rule-in diagnosis, so a positive diagnosis, which is, as we're starting to see, much more helpful for the patients. So again, just a summary for DSM-4 to DSM-5 and the changes. However, but what about cognition? And you'll see that there's different, I'm going to go into the different presentations, but cognition, dizziness, how should comorbid pain, fatigue, and autonomic systems be conceptualized? Why are they important? Why are neurological disorders important? Well, I had to change this slide because, you know, years ago it used to be the second most common presentation in neurology, but I think latest stats are the most common presentation in neurology. And actually functional limb weakness is the most common presentation in FND. And to date, although it is changing, I'm really pleased to say that, you know, they've reported poor intervention and outcome. So a high number of patients with poorer intervention and outcome, and actually limited research, but again, that is changing. And also FND is a condition at the intersection of neurology and psychiatry, and sometimes it was historically maybe a bit controversial. Some patients don't like the term psychological or don't like the inference that psychiatry is needed within this condition. It can be taken as, I'm at it, it is in my mind, there's nothing wrong with me. And I think part of the assessment and diagnosis is taking time to get them to understand that. And FND is a long history and debate on understanding how biopsychosocial factors contribute to the manifestation of the disorder, and how that's explained to patients would be really, really important. And there's recent evidence about, the panic model being integrated, and, emotional regulation models and things. Again, I'm going to mention that a wee bit later. Okay, so again, this is on YouTube, and just an introduction. It's important to hear from our patients.
In an ideal health service, all doctors and professionals would be actually made aware of this. And we wouldn't be treated as though, not like we're faking, but almost like as though it's not real. And that doesn't really help us, because we're thinking, oh, what's wrong with me?
Exactly, straight from the patient's mouth. And I would say that in my 30 years, that's exactly what patients say to me. It's so important. If we went to the doctors and they said, oh, well, you don't have this, you don't have that, you don't have, but you still have symptoms, you're left with, well, what is it? And that can cause more distress and upset. Oh. So functional disorders often persist, again, just to give you papers, that you're probably all aware of, to back that up. And they're very disabling, or can be, actually, is the right thing to say there. They can be very, very disabling. And that doesn't mean to say they're not treatable, though I've seen patients that have had a diagnosis 30 years ago and can still make changes. And so very, very important. Clinical trials in FND, there's guided self-help, internet-based ones, again, papers for those. The two that I was actively involved in for 3-4 years were both the CODES trial for dissociative seizures and the Physio for FMD trial. And I'm going to mention a bit about both of those. I was active in them for, about 4 years for each of them, and both have finalised, but there'll be ongoing work forward to, actually. So FND treatment pathways, 2012 healthcare improvement, just again looking at a sort of step care approach, which is common with a lot of conditions, actually. And I've put Johnstone and Alan Carson in there just because they're part of the FND team, just to demonstrate and the experience that they've had. They put aside at least an hour's appointment, which a lot of neurologists will say, well, I just don't have time for that. But what if they've found that actually really improves outcome? Because, at that point, patients can actually have a huge turnaround as to improving. And the more complex ones tend to move to psychiatry, psychology. We're hoping that psychology is involved earlier on. Something else I was going to say about that, and actually again, evidence, which I'll say later on, is that the multidisciplinary team is vital to the success from a lot of the research studies that have been ongoing. I wanted to mention this paper, but again, go to it, you've probably seen it, but actually, actually, this is a different one I was thinking about. I'll mention this one first, but neurological assessment is treatment. So that's why Johnstone and a lot of neurologists, I don't know the stats, but will put aside, at least an hour for assessment. That actually the assessment and the diagnosis can bring a huge turnaround. Certainly, even when I spent time, even a couple of sessions with a lot of the patients over the years, that actually just them understanding what they had helped them to get better, and knowing that makes a huge difference. So some key points to diagnosis: it can be difficult explaining a diagnosis, but it's vital to recovery, which is just what I've said. Follow the normal rules of explanation, like we would do, tell the patient what it is and not what it isn't. show the patient the positive rationale for the diagnosis. So now that's something like Hoover's sign. I've got some videos for you and I'll explain that a little bit more, but there's different things that can give the positive signs. This is an old video, but actually a very young John Stone there. So I'm going to go through just a few symptoms that you might see in FND, but I'd need all day to go through all the different types. So FND can be seen as an umbrella term, and there can be subcategories, which I'll go through some of those as well. But so often patients present acutely with like stroke-like symptoms. Key signs might be the Hoover's sign. John Stone in this video does it. I might play it twice just to explain as we go along, but thinking about the difference between automatic movement and non-automatic movement, you know, we think about the speed of movement, the tone. There might be excessive effort when patients move, reflexes, things like collapsing or giving way, weakness. But again, I'll talk through that as I go through some of the other videos I've got for you today. And also thinking about difference between, you know, this is examination in the bed, but you would think about an examination in the chair, etc. as well.
And then just stop it pushing as well.
Okay, I might play that again, but then Professor Stone is carrying out the Hoover's test there. There's a weakness on the lady's right leg and the hamstrings pushing down onto the bed. And so by distracting or getting the patient to focus on the right leg, get my lefts and rights mixed up with the video, the movement, automatic movement kicks in on the left leg. So the weakness is, I think he said a grade 3 there, but actually it improves. So again, moving into an automatic pathway. And again, you can do the Hoover's test in sitting, my lovely model there. So again, if there was a weakness on the right leg, so if I was pushing up to try and get the leg off the chair there, that would probably lift it quite often easily in a patient with right-sided weakness. So I would then ask the patient to really concentrate on the left and push up against my hand, and that the strength would kick in on the right leg on that side. Now again, I would encourage people to not feel frightened to do that, no matter what your profession. You're showing the patient hope that things can change. You're not tricking them. You're making sure they don't feel tricked. You're showing them that the nervous system can actually kick in and the movement can be shown in that situation. So depending how you do it, that can be really, really helpful for patients. Patient observation, and again, done in the same way. You know, you might ask a patient, or even just watch them as they come into your clinic. You know, as they go to leave and they put their jacket on, the arm that was not moving might flicker in or start to, when you're talking to them, they're distracted. And you might see some automatic movement responses coming in. And again, I would point that out to the patient, but not in a judgmental way, in a way that, look, we can access the movement in the nervous system, so we can actually, there's potential to get this better. And I would say the majority of patients I've seen, that's what they want to hear, the majority. So again, thinking about common symptoms, this is again a weakness disorder, but in a different, so looking at it in gait.
Stand up for me. And if you, would you be able to walk without, or just think you? Walk without, just go behind you. Just a short piece of that. And then just come down. And then just sit down again.
Again, seeing those patients in clinic and understanding that actually to walk like that actually uses a lot more effort, and there's more likely, there's great strength there to be able to drag a leg behind you. But it's really important that, a new pattern has been learned by the brain. And so part of the treatment will be just relearning a new movement pattern back to normal. And also part of the treatment will be activating the automatic nervous system. So, if even during the assessment, you could actually even get the patient to stand and do some things with their arms. I've got loads of videos, I wish I had more time. Do something with their arm, and you would find that even just by transferring weight, the leg would kick in an automatic way. And that would be how you would break down treatment, or, if you were doing it in therapy, you might break down treatment. But if that happened in the clinic, again, just to as part of the assessment and diagnosis, you might go, look when we're distracting and the brain is not focusing, and I'm going to talk about attention, it's not focusing on the problem area, then we can actually access the movement. So examples of positive signs, again, don't have time to go through them, but you're probably very aware. There's the Hoover sign, hippoductor tests, and there's ways of testing them out to show that we can actually access the nervous system. Global weakness, I've got some videos for tremor, etc., and dystonia, which I'm going to show you as well as we move through. And this is another one where we're starting to introduce the bringing in distraction, bringing in task orientation to functional movement disorders, and getting the brain to focus on the task rather than the problem actually accesses. I'll just show you this video.
It feels like I am manually trying to get my legs to move as opposed to them wanting to do it of their own volition. So I'm having to think through what it is I'm trying to do as opposed to just doing it naturally.
I see you hiding, yeah. And walk backwards towards you.
Walking backwards is the one that's something I normally do, walk backwards, no. But no, that's I mean, that was a bit of a revelation, to be honest. I'm not having to think about that.
Yeah.
So some really key things in there that I'm not having to think about it. I'm not having to think about walking. I'm thinking about the task. So the patient was asked to think about skating or skiing or whatever. And actually, if the brain was task orientated, the automatic response was kicking in. And he said it was a bit of a revelation. It was amazing that the movement changed like that. And so it's not part of tricking the patient. It's so important to do that. It's about part of, look, we can access this. How can we build on it? How can we build on our treatment and get this better? Another common symptom that you'll see in functional movement disorder is tremor. And again, I'm going to play this and then talk it through. Again, demonstrating there, happy to play it again if anyone feels. This is called entrainment of the tremor, but also through your diagnosis, I'm not here to teach that, as most people will know, the onset can be different with functional, it's often acute rather than a longer term onset, but using things like entrainment or distraction. So we started off as counting, I think he was counting backwards actually, and you'll see a difference in the tremor amplitude as well. Moving the fingers and tapping, you were getting the the same beat within the tremor, and then using the finger to point at the finger. The tremor in between movements was just stopping, which you would not see if there was damage to the central nervous system. So again, starting to think about the role of attention within this diagnostic criteria, and the role of expectation as well, which is part of it. And I feel I have to mention this one as well, which is extremely disabling, and actually also to introduce to you the fact that you're going to get secondary complications that need treated as well, and that's a difficulty if somebody's had the condition for a long time.
When you look at the foot, you can see that it's bent, obviously.
Yes.
Yeah. Can you just close your eyes for me now, and just tell me what that left foot feels like with your eyes shut?
It feels like it's straight.
Okay. It feels completely straight.
Yeah.
Okay. And then when you open your eyes and you look at it again,
And then I can see it's bent.
yeah.
Over.
So is that what is that? Is that a strange feeling? That difference between?
Yes, it feels strange because although the foot's bent and I know it's bent, when my eyes are shut, it's straight.
Again, introducing that there's going to be secondary changes, you know, if a limb is stuck in that position, there's proprioceptive changes there. You're going to have swelling, you're going to have shortening of tissues over time. And again, the sensory problems, the pain that's associated with it, that again can, so just to introduce the secondary problems that are coming there as well. An onset maybe in adulthood of it might be a clenched fist or an inverted ankle, and fixed. It's going to be a fixed posture that's happening there, and very commonly associated with pain. Often precipitated by a minor injury or trauma of some sort, and we'll talk about precipitating factors a little bit as well. And another one, now there's plenty more, but these are the main ones that I wanted to introduce today, but obviously dissociative seizures, and at the moment it was the video I could find, but it's an old one, but just to introduce it, you know, 1% of patients diagnosed with epilepsy, the stats might be slightly different, 5 to 20% actually have dissociative non-epileptic attacks. And again, this is just showing how distraction or changes, trying to talk to the patient during the attack. I worked for 3 years in the CODES trial and saw a huge difference with all the patients. I think I saw 200 patients with dissociative seizures, and happy to talk at another time about that. And I'll briefly discuss the intervention we did on the trial.
Good, good. Keep flowing. It's definitely going to come again. Soft. It's still continuing. Peanut butter. Eyes are wide open. I don't want you to deep breathe like that. Just relax. Lift your right leg up in the air. Lift your left arm up. Point to the ceiling.
A lot of the patients are presented, I'm maybe jumping the gun, I've got a few more slides for this, but you know, the variance in dissociative attacks were massive. You know, I saw people that maybe had 1 a week to 20 a day, and very variable. And the treatment, if it's non-epileptic, is completely different. I've got a few slides about that, and I'm not introducing medical care at all here, but we worked to a protocol, we worked within, as I was a clinician, to CBT, and I'll talk a bit about that for the trial. And the difference between some of the things you'll find dissociative and epilepsy, which I find really, really interesting, even just down to resistance to eye opening will be common in dissociative, but rare in epilepsy, and eyes shut during attack, common in dissociative, but rare in epilepsy. And some of the other things, the differences that you can find. Again, some of the people listening here, I don't need to tell you that, but really, really interesting in the differences. Okay. This is the paper that I was thinking I was presenting just a bit earlier. So again, go and look this one up. Don't have time to go through it all, but just how we explain what the patients have in any clinic, doesn't need to be a neurology clinic, you know, because often depending how much time the neurologists have, who tend to be the one that diagnose, physio, psychologist, clinical psychologist, psychiatrist, whoever sees them next, it's still part of our job to reinforce and support that. And that's why the team is so effective. I love this paper because it was done almost as a cartoon. And it's a great representation. Well, initially, that's, I think, a later page, but initially the earlier pages are showing what not to say, and this is one of the pages that goes through, you know, the best way to go through it and explain it. You know, you have functional leg weakness, your nervous system's not damaged, but it's not functioning properly. And then obviously patients often say, well, what can I do about it? And there's no quick fixes, but physio, psychology can help you understand the problem better and learn how to manage it. And the importance of giving information, clinical sheets. I'll introduce you to John Stone's website. I've got downloadable sheets for explanations for patients that are really, really helpful. So as we all know, even ourselves when we're in a clinic, we don't remember things when we go away. So it's good to be given information and have that as a support so that patients truly understand what's going on. So I encourage you to look at this paper and go through the pages of it. So the power of the right diagnosis. So important, and I'm just trying to back up evidence base here and some of the things that I say and give you access to papers that are out there. And this year, actually, John Stone and team involved in, you know, Functional Neurological National Pathway, which was evidence-based and on any systematic reviews out there and consensus recommendations. So this is now available, an extremely helpful paper. A summary of the recommendations are given here, but it goes through each and every one of those and a good reference list to back up there. So again, encourage this to be in each department. And I know not when pathways are recommended, we don't always have the facilities or the staffing or whatever, but knowing what we're working towards to provide evidence-based care for our patients. I can give access to this as well. Okay. So currently at the moment, we have consensus recommendations. We don't have guidelines as such, but we have consensus recommendations. And again, I've been involved in a lot of them. I've been involved around the physio ones early on and helped to write the occupational therapy ones because we had a mix of professions in there. It's the latest speech and language therapy one that's just been done. And also systematic review of psychotherapy for adults with functional neurological disorder. So currently consensus recommendations and a link to the trials that are ongoing as well at the moment now. So this is more related to the systematic review for psychological interventions. The review supports the use of psychotherapy for FND in clinical practice. And one of the reasons why I really trained as a cognitive behavioural therapist, and so both CBT and psychodynamic therapy are dependent on the patient's accepting psychological factors. And I found that even just in my very, very early career as a neurological physio, that patients have got to be on board. They've got to not feel threatened. They've got to not feel as if they're making it up, etc. And that, to me, that's part of the therapeutic relationship that all of us should strive to work towards. We know the therapeutic relationship is a massive part of treatment. And so, again, if patients initially, I've had loads of patients that initially not accepting of psychological factors, but I've worked to get them to understand what that means, or and it's maybe just not been explained to them properly. And as always, looking at the patient's perspective, the important thing to quote from a patient, the important thing to remember with FND is that there's nothing structurally or physically wrong with my body, and the brain pathways to all of my body parts are intact and able to receive brain signals. The central nervous system requires to be retrained or reprogrammed, is the way they're thinking of it, to relearn how to connect and communicate with my body again. And I thought that's a nice way to explain it, and patients understand really well. So I've started to mention a bit about the attentional spotlight, and it's such a part of this condition. And it can be a part of lots of conditions if we think about it, where there's an over-attentiveness to certain symptoms. We can see that in things like health anxieties, you know, any panic disorder type presentations, and a lot of different conditions. We know that attention to symptoms or attention can actually, as we sometimes explain to patients, turn up the volume on symptoms and actually make things worse. So functional symptoms require attention to manifest, and demonstrating this to the patient and redirecting attention. So that's where we might distract or use the term distract, but I prefer redirecting attention during the movement retraining can be really helpful. Does your movement get worse if you think about your limbs or your body? Or does the symptoms that you've got get worse if you think more about it? Does your movement improve with distraction or with more automatic movement? And again, we're starting to get to see the patients, not only to understand that they can get better, to understand how it's actually manifest in the first place. So attention to the body can impair normal control of movement because it's an automatic process. The brain can learn a new program and select the wrong one over time. Attention interferes with movement. And I sometimes explain to patients, you know, think about it when you're learning a new sport. You know, if you're tennis, for example, badminton, whatever, something like that, you're starting to learn how to do the serve. Over attention to it, it just goes to pot until you practice, and then you don't even think about it. You can even talk while you're doing it. It's become an automatic program within the brain, and I sometimes explain that to patients. Okay, so starting to integrate some of those stuff into just, you know, what happened in the two trials that I was part of, just to talk a little bit about in the time that we've got today. So the CODES trial, this is the website that you can access, and there's all the recent publications are on there now. And I think actually the workbook that we used for the trial is on there and accessible and really, really interesting. So it's, you know, a multi-centered randomized control trial involving CBT and standardized medical care compared to standardized medical care. And I've got a little video just to give you an explanation of the outcomes for that trial. But there's several papers being published now, and not got the time to go through it all with you. But while I was carrying out the trial, it's 3 years, I think I saw several, must be hundreds of patients. And again, just the difference and understanding that if you're working in a team, you know, everyone on board and everybody educated within and understanding the condition is so important. Because one of the things that I remember when I worked within the clinics, that when I was seeing the trial patients, a lot of the nurses, if someone took a seizure, then, you know, press the alarm button and send, you know, for accident emergency or the emergency button, which again was not helpful. And part of the protocol was just to carry on, let the patients come out of the seizure, tell them just to come back, you know, to just sit up or whatever happened with the seizure and continue with your trial treatment as part of the protocol. And that felt quite hard as a clinician. And also to give the patients, I can go through the treatment techniques, but, you know, distraction techniques within. So, but the important thing there was, you know, if you're working as a team, those patients didn't require the emergency button. They didn't require to go to A&E within the trial setting. And once the nurses understood and they knew what the condition was, we worked together with it. And again, just emphasising the teamwork that's important for this. Okay, this is a video that's accessible now, great for patients, great for clinicians that are just understanding what dissociative seizures are, and it gives you some of the outcomes for the trial.
Dissociative seizures can look like epileptic seizures or faints, but they aren't the same. While epileptic seizures are caused by a sudden, abnormal electrical discharge in the brain, dissociative seizures may be explained by a process called dissociation. It's as if the brain has been temporarily switched off. Dissociation describes the feeling of being cut off or disconnected from your surroundings or your own body. The feeling of dissociation is very common and happens to all of us. It can be mild, like when you're daydreaming, or when you're concentrating on something and don't hear someone speaking to you. Dissociation can also be more severe. This is what happens in a dissociative seizure. medication to treat epilepsy is ineffective for dissociative seizures. There's no consistent treatment pathway in the UK for patients with dissociative seizures, so a study called the CODES trial was developed to identify what treatments work best. The trial was conducted across England, Scotland, and Wales, and was the largest trial to date for people with dissociative seizures. Everyone in the study was first seen by a neurologist, then a psychiatrist. This was called standardized medical care. The neurologist established and shared the diagnosis of the patient. The psychiatrist got to know the person better, establishing factors that provided a way forward for treatment. 186 people of a total of 368 were allocated at random to also be seen by a cognitive behavioral therapist. Cognitive behavioral therapy, or CBT, is a talking therapy, here aiming to improve control over seizures and helping people re-engage with everyday activities. Our main outcome was how often people had seizures. 12 months after starting the trial, both groups had similar numbers of monthly dissociative seizures. However, patients who received CBT did better than patients with just standardized care on a range of measures. They had longer periods between seizures, were less bothered by their seizures, reported better health, and felt better able to function in everyday situations. They and their doctors also considered that they had improved more than patients who hadn't been offered CBT, and these patients were more satisfied with their treatment. In other measures, there wasn't any difference between the groups. The CBT group didn't show an advantage in terms of reduced numbers of seizures, but the CODES trial showed that having CBT, in addition to being seen by a neurologist and a psychiatrist, may improve how people with dissociative seizures feel about themselves, their health, and their seizures.
Okay. Again, a helpful video to share. We did use a fairly as standardized as you can get protocol, and the workbook is available. I have access to that. The treatment in terms of CBT were around looking at grounding techniques, distraction techniques. I'm going to talk about, depending what, if somebody had trauma in their life, whether that was necessary, if that was something that we think manifests the condition. And, dropping safety behaviours. A lot of patients with dissociative seizures, as you can understand, develop so many safety behaviours. They're frightened to go out, they're frightened to do everyday things. There were behaviours that were actually, as described, or felt as if they were keeping them safe, but they weren't learning new beliefs of, I can do this, the seizures are not so frightening. A common one that I came across was, I have a seizure. Oh, there's a background noise. I don't know if somebody's not got their microphone off. If I have a seizure outside, what if somebody mugs me? What if... and we had to do like behavioural experiments to change those cognitions. And there was times where I had to take patients to the park, pretend I had a seizure to let them see the outcome of that. And so they have to be set up very, very carefully. I'm not saying that lightheartedly, but you're looking at changing cognitions, changing beliefs, dropping safety behaviours, and every single patient was different. I could talk all day on that, actually. It was really, really interesting. Okay. And again, just highlighting the papers, but you can access all of them on the CODES trial website. And again, just looking at the role of dissociation, it's been cited as a possible psychologic mechanism underpinning functional neurological disorders since early on, actually. And FND ranks 4th among 19 common psychiatric conditions in terms of the highest self-reported dissociation scores. And again, understanding it helps, obviously helps with treatment and future research. Time flies, and so what I want to just introduce some of the expanding phenotypes that come under the FND heading, and again also really introduce some of the world leaders that are coming out. And I worked with Laura for a long time around the CODES study as well, and her speciality looking at functional cognitive disorders, and has got recent systematic reviews Also, a really helpful fact sheet that Laura's got on the neurosymptoms.org website is, which I think is part of treatment for any of the phenotypes, is normalising memory problems. It was in the Times, and some of this information where there's lots of people presenting with, at Alzheimer's clinics or memory clinics that are actually functional cognitive disorders. And again, the attention to the memory. I've got a patient at the moment that I'm working with. The attention to the loss of words or the memory actually makes it worse, and the expectation you're not going to have, you're going to have difficulty with your memory, heightens those symptoms. And it also just changes the cognition. There's something wrong with me. This is worse than it should be. And part of the treatment can be normalising that. And there's a great fact sheet that's great for patients to normalise what the normal memory is like. That walking out of a room and forgetting your keys most days is actually part of my problem, but actually is very, very common in the normal person, never mind functional. And other areas, can't say this fast, but persistent postural perceptual dizziness, triple PD, and again, I've treated loads of patients in that area as well. And Stoyan, again, is part of our team and has written really good, there's good models for all those different areas, a really good CBT model out there for this condition, as is, I'm thinking of the Ruber paper, 2009. There's a really good model for dissociative seizures as well. Again, really helpful with patients. I've mentioned the codes, but I can't finish without just mentioning the physio for FMD. And again, that feels years away because I was involved right at the beginning, and I had done my master's in CBT at that time as well. So use some of those techniques within the trial as well. So again, multi-centre trial. It was Glenn Nelson, and it has completed. I'll go through that model in a second. With some good outcomes. That one of the areas that it's going to look at is though that we couldn't have no treatment, so it was community treatment alongside specialist treatment for FND with improvements, but not dramatically improvements in both areas. But again, just don't have time to go in. There's several papers published now that they show all the outcomes. But within this, there is a workbook that you can download again in terms of treatment, and some of the model within this, I'll just actually put all the things on the model there just to quickly go through it. But I use this model, it's like a formulation really with patients, just again to help them understand, because there's, again, looking at risk factors, like any condition, risk factors, are still understanding it in FND. There might be biological, there's a history of illness or a history of disease. Hypermobility seems to play a role, which still understanding migraines, pain, anxiety, whether there's been an emotional disorder of some sort. And that, again, the Stoyan has just written a recent paper around the emotional manifestation or disorders that might manifest this condition as well. And adverse events. I would say a very high percentage in all the patients I've treated have adverse events or some sort of trauma or abuse, but not all patients do, so we can't say that as the absolute cause, or there might be social as well, neglect, family dynamics, things like that. And again, it's helpful for patients just to understand, why me? They often say, well, why me? Why have I got this and not anything else? And there's usually a trigger that comes along. But again, that's similar with a lot of conditions. It might be a recent bereavement, an illness, an acute panic attack. Patients often describe some sort of panic disorder in their history as well, or dissociative episodes. And again, it helps us to understand, where do we need to target our treatment. Flight or flight, it's been well known to, I say to patients, well, it's like they recognise this is, this is sort of almost simplified for patients, because flight or flight does play a role at whatever level, and patients just understand that. So I say it's like a smoke alarm that's going off at times at the wrong time, and they get that, and they quite like that analogy. And I talk around the attention and the expectation that movement's going to be abnormal if it's a movement disorder, or something's going to be abnormal. And I sometimes use the analogy of, well, if you go into a room and you're asked to pick up a huge big box, your body prepares to pick up that box because it's expecting it to be big and heavy. But then if you pick it up and it's empty, you probably stagger back. Well, that's because there's expectation there. And the body has automatically prepared, but it's not prepared in the right way. And also just looking at the vicious cycle that goes on within the secondary changes if things are not treated or moved. It goes on. So again, this sort of model type formulation was used in the FMD trial, and there's other models and things that are in literature now that really help to support or get the patients to understand what's going on. And again, just to look at attention and the expectation of movement, I've got a couple of nice videos just to go through with you.
In some regards as well, because I tried to have a positive attitude for a lot of it, but when you just don't seem to be making any progress, I didn't feel free. I felt very, very trapped in hospital. It was really amazing when I could run again.
I have never seen someone like Miranda before. And even though she could not walk or she could not even stand by herself, I took up the challenge to put her on the treadmill.
My mum was there filming at the time, and she thought that it was crazy. And then he just made it faster and faster. And that's when we discovered that I could run. I could go quickly, but not slowly.
So again, backing up what I've said, I could go quickly, but not slowly. Slowly usually brings more attention and more willing the body to move. Quickly kicks in your automatic responses. So again, that might be part of treatment. And I don't have enough time to go into all of that today, but and again, I'll just follow on.
That was what really got me going. If I can run, I can figure out how to walk. And that's when we really started getting innovative. We realized that I needed to retrain the way that I was thinking. I left the Royal Brisbane and went to a rehab unit in the hope that I would just one day just walk. We had no idea how long it would take. And eventually that's just what happened.
Do it again for me.
Sam and I, we were in depth conversation, and then it wasn't until we were halfway down the street that we both realised that I was walking like normally.
That is a miracle.
My biggest fear then was to stop walking. I just kept walking because I was like, if I sit down and stop, what if I can't walk again?
Maybe you picked up that she said we were walking down the street and I was deep in conversation. So again, just backing up that when they were distracted, deep in conversation, the brain was focused on the task of talking about whatever they were talking about, the automatic response kicked in. I know these are movement or more physio videos for this particular one, but not to forget that, you know, thinking about the model, if somebody had a history of trauma, they're worried about why me, you know, this is why the team is so important. I would say most of my patients, in my experience, I can only speak with it, welcomed psychology input, welcomed, you know, trauma treatment if it was necessary, and welcomed that once they understood the mechanism or what, you know, what may have been involved in them being more susceptible to this condition. Again, I've got a link for some of the books and some of the chapters that I've been involved with for writing, but some of the common things that we felt were so important, and I know this looks busy, and I don't doubt that everybody here will know this, but just thinking about unconditional, no matter who you are, what type of work you do, unconditional positive regard for this client group, no matter what the client tells you, do not judge them verbally or non-verbally. It's in my long career of working with this patient group is so important. The empathetic understanding, this is communicated to the patient through listening, acknowledging symptoms. So going back to thinking about assessment and diagnosis, I would get the patients to write down every single symptom they've got. And I know you think, oh, that might take forever, but you're acknowledging what they have got and actually helping them to work through it and summarising so that you're understanding. And non-verbal, just remembering our own non-verbal, consider eye contact, body positions are so, and congruentness, genuineness, being honest and authentic. And if we don't know, saying that as well, the patients can tell, and they like to know that you're, you know, if you don't know something, you will find out or you will go. and the patient should not feel at fault. It's again just a common thing that patients have said to me, it's my fault, I've done this. Or actually, you know, if there's historical abuse, I've been bad, or that, you know, that just looking at what beliefs are there as well, that might need to be changed or accessed. And a good phrase to use, you know, people do things for very good reasons, or they behave in certain ways for very good reasons, depending what you're working with, whether it's, you know, looking at personality traits as well. You know, a common one is perfectionism, actually, with this patient group, fear of failure, perfectionistic traits, very, very common in working. I'd say that's a big part of my work still today, is working around core beliefs of I might fail and perfectionistic behaviours that are very, very difficult to drop and work with. I'd say that's part of my work as well. So some of the top tips: indicate belief always and empathy, emphasise potential to improve, be creative. I smile at that one, but no matter who you are, and again, you know, being creative in how you show the patients that you can normalise movement or normalise cognitive symptoms, for example, is really, really important, and thinking of different ways to do that. It can be hard, actually. Discussing relapse is really, really important as well, because it's actually very common in this group. And so again, not getting them to be frightened of it, or not to see that it's catastrophic often, and that they've got part of the, I think anyone treating should look at it as a self-management process. You're giving the patients tools. If they do relapse, they've got the tools, and they're confident in the tools that they've got in order to re-implement the tools that you've worked with. So you're shifting from disability to mastering an activity. And you're supporting self-management, as I've just said. And I say with every patient, I would give them a workbook or a file or something that they're really understanding. That's very CBT orientated as well. They're understanding what tools they've got, and it's them that are doing it, and they can work through it. And I think this one should be at the top, though, a good therapeutic alliance. Like, huge evidence to support that, certainly in CBT. That's actually a main part of getting patients better, and the multidisciplinary care gold standard. So just, in my watch a minute to go, so just about there. This is John Stone's website that is developed all the time. It's got everything on there, actually, neurosymptoms.org. There's downloadable fact sheets, education, fantastic website, not only for clinicians, but for patients. There's also an app, Neurosymptoms FND Guide, that you can access as well. It's a case studies book I was involved in as well. It's got different case studies, which hopefully are helpful when you go through them. And these, to date, are your sort of Bibles. Again, I was involved in a chapter with Glenn Nelson for a functional movement disorder, and bringing in some CBT techniques. And this is really your handbook of clinical neurology. I love this book for all. And again, I'm sure it'll be reviewed and updated for up-to-date evidence-based practice for FND. And encourage you, as you get commissioned for this, to join the FND Society if it's a passion of yours. There's ongoing training, there's conferences every year, and again, great networking to work as a team. So FND, it's very common, it's very important, and it's potentially treatable. Thank you.
Thanks very much, Paula. As you alluded to there, we're right up against the wire in terms of time, and I know people have clinics to get off to, not least myself. So there's no questions in the comments as yet, but I think if anyone does have any questions for Paula, I'm sure she'll be happy to look at them later. If you want to email me, I can always pass them on to Paula. Thank you very much for rounding off our Grand Round programme this year. Thanks to everybody who's taken part throughout the whole of the year, or if you've been in the audience, if you've watched on YouTube, if you have been a speaker, or if you've pointed someone in the right direction to come and find me so I can put them on the spot. I hope you have a good summer holiday away from Grand Rounds, and if you'd like to speak at Grand Rounds next academic year, please get in touch with me so I can put you on the roster. Thanks very much, everyone, and thanks again, Paula.
Pleasure. Thank you.